Welcome back to the Vet Scholar, where we continue our deep dive into canine epilepsy. In the previous episode, we explored the basics of epilepsy, including the types of seizures and how to identify them. Today, we'll be moving forward into one of the most critical parts of managing epilepsy, treatment. Specifically, we'll be focusing on anti-epileptic drugs, AEDs, and how they're used to manage seizures in dogs. But before we get into the specific drugs, let's first talk about the overarching principles of seizure management. The primary goal is to balance controlling the seizures with minimizing side effects. This includes deciding when to start treatment, choosing the most appropriate AED and dosage, knowing when to monitor serum concentrations, and of course, when to add or change medications. Perhaps most importantly, we need to ensure pet owner compliance. This journey is a partnership between the vet and the owner, and managing expectations is key. So, how do we decide when to start AED treatment in a dog with epilepsy? Guidelines suggest starting medication when a dog experiences 2 or more seizures within a 6-month period. If the seizures occur in clusters, or we're dealing with status epilepticus, a prolonged seizure, this warrants immediate intervention. We might also start treatment if the post-ictal signs, like aggression or blindness, last longer than 24 hours, or if the seizures are getting worse in frequency or severity. Ultimately, the decision to start treatment is tailored to each individual patient, depending on their quality of life and the potential risks. Let's begin with one of the most widely used AEDs for dogs, Phenobarbital. This drug has been around for a long time and is considered a first-line treatment for dogs, and even for cats, although it's less commonly used for them. Phenobarbital works by increasing the brain's response to GABA, which is an inhibitory neurotransmitter that helps calm down overactive neurons. It also has some anti-glutamate effects and reduces calcium flow into neurons, all of which help to reduce seizure activity. Once administered, phenobarbital is metabolized mainly by the liver. Its half-life is pretty long, anywhere from 40 to 90 hours in dogs, and it takes about 10 to 15 days to reach steady-state concentrations. Although there are recommended starting doses, this can vary depending on how well the seizures are controlled and how the dog is tolerating the drug. Monitoring serum levels is crucial when using phenobarbital. We usually check the blood levels 2 to 3 weeks after starting therapy or changing the dose. The target range we aim for is between 20 and 35 micrograms per milliliter. Monitoring helps us make sure the drug is working effectively while also keeping side effects at bay. Speaking of side effects, sedation, ataxia, and increased thirst and appetite are quite common, especially when treatment first starts. Thankfully, these often improve after a few weeks. However, in some cases, more severe issues like liver toxicity or blood disorders can develop, though they are rare. Elevated liver enzymes are common, but these don't always mean liver disease. So it's important not to rush into discontinuing the drug without proper evaluation. Phenobarbital can also affect thyroid function, decreasing thyroid hormones, although this doesn't typically result in clinical hypothyroidism. Overall, phenobarbital is effective, but like any drug, it comes with its own set of challenges. Next, let's talk about bromide. This drug is another common choice, especially for dogs where phenobarbital isn't quite cutting it, or if liver issues are a concern. Bromide works by hyperpolarizing neuronal membranes, making it harder for seizures to occur. The key thing to know here is that bromide is excreted through the kidneys, making it a good option for dogs with liver disease. The half-life of bromide is impressively long, about 24 days in dogs, meaning it can take between 80 and 120 days to reach steady state. A slow start for sure, but that long half-life also means that it sticks around longer, making it easier to manage once we've found the right dose. One of the downsides is that side effects can be dose-dependent. You might see pelvic limb stiffness, sedation, and even vomiting in some cases. Another concern is that bromide competes with chloride for elimination through the kidneys. So, if a dog's diet suddenly becomes high in salt, for example, that can speed up bromide clearance, which can interfere with seizure control. Monitoring serum levels after a few months of treatment is crucial to make sure everything's working as it should. Overall, bromide is a solid choice, particularly when phenobarbital alone isn't enough, but it does come with its own quirks, especially when it comes to side effects like ataxia and gastrointestinal issues. Diazepam is another important drug in our toolkit, although it's not typically used for maintenance therapy in dogs because of its short half-life, only about 2 to 4 hours. Instead, we reserve it for emergency situations, like status epilepticus. Diazepam works by enhancing GABA activity in the brain, and it's metabolized primarily by the liver. It's a drug we can use intravenously or rectally for fast action during an emergency. It's worth noting that diazepam isn't ideal for long-term use in dogs due to the short half-life and development of tolerance. Notably, oral diazepam in cats carries the risk of fatal hepatic necrosis. Despite its limitations, diazepam remains a critical emergency drug for seizure control. Now let's shift our focus to zonisamide, a second-line drug that's becoming increasingly popular. Zonisamide has a complex mechanism of action, affecting both sodium and calcium channels, and it also binds to GABA receptors. Its half-life in dogs is around 15 hours, and it's metabolized by the liver. Interestingly, zonisamide's metabolism can be affected by drugs like phenobarbital, which speed up its clearance. When used alongside phenobarbital, we typically dose zonisamide at 10 milligrams per kilogram every 12 hours. This keeps serum concentrations within the therapeutic range. It's generally well tolerated, though some dogs might experience sedation or ataxia. It's particularly effective as an add-on drug, with studies showing a significant reduction in seizure frequency in dogs with refractory epilepsy. While side effects are generally mild, there have been reports of hepatotoxicity and even renal tubular acidosis in some cases. Still, zonisamide offers an excellent option for dogs who aren't responding to first-line treatments. Finally, let's look at levetiracetam, a drug that's known for its high safety profile. Its primary mode of action involves binding to the synaptic vesicle protein 2A, which plays a role in reducing seizure activity. Levetiracetam is almost completely eliminated through the kidneys, with a very minimal amount metabolized by the liver. This makes it a good choice for dogs with hepatic issues. The half-life is quite short, about 4 hours. But interestingly, its effects often last longer than the serum concentration would suggest. The recommended dose is 20 milligrams per kilogram every 8 hours, and side effects are rare. If they do occur, they tend to be mild, such as sedation or ataxia. One thing to watch for is that its metabolism may be accelerated in dogs also taking phenobarbital, so dose adjustments might be necessary over time. Levetiracetam can also be used in pulse therapy for cluster seizures, and it's available in an injectable form for emergency situations. Overall, levetiracetam is well tolerated, especially in combination therapies, making it a versatile option in canine epilepsy management. And there we have it, a deep dive into the drugs used to treat canine epilepsy. Remember, each patient is unique, and managing epilepsy is all about finding the right combination of drugs and doses that control seizures while minimizing side effects. Thanks for tuning in, and as always, if you found this video helpful, be sure to like, subscribe, and hit the bell for notifications on future veterinary education content. See you next time on The Vet Scholar.